Yeah. Thanks, Julie. That was fantastic. Really appreciate you pulling that together for us. Want to bring up our panel if we can, and we will introduce them. One of my colleagues on the panel is Marianne Dubargol, who is internationally trained, as she's from France, and attended the University of Medicine in Lyon, France, and graduated from there and with a master's in biochemistry and molecular biology. She went on to clinical fellowship at the University of Bordeaux, and also trained in Réunion Island, France, for her oncology training. But she also came here to this country and did a medicine residency at Penn and cancer genetics program at Memorial. So she brings the two fields together for us, and is running our cancer genetics program at the FHCC. I think one of the challenges we have here is, for people who have a predisposition to cancer, how do we work that at an international level? So that'll be one of our panel questions. You want to introduce the others?
Sure. Great panel. Thank you. Next, LaToya Williams. And Ms. Williams is the National Strategic Director of Health Equity Community Initiatives at the American Cancer Society. She came highly recommended from Dr. Karen Knudsen, so no higher compliment than that. She's been working to improve access to care, promote cancer health equity, and reduce cancer screening disparities in underserved communities. And also joining us, and you may remember her from yesterday, Dr. Van Loon. And Dr. Van Loon is a specialist in GI malignancies with a background in public health. Her focus on epidemiology. She has a master's in public health from the Yale School of Public Health and is currently at UCSF. And as if you heard her talk yesterday, you know that you're in for a treat today. So we'll go ahead and get started with panel questions, and also then have some time to have questions from the audience. But we thought, one of the things we're thinking about is how to interject the voice of the patient. And in addition to all of her accomplishments, Ms. Williams is also a 15-year breast cancer survivor. She has lost several family members to various types of cancers, and it's really her survivorship that has given her the passion to address cancer disparities. And we just thought you might kick us off, because your experience is what gives meaning to all of this.
Thank you so much, Dr. Lopez, and thank you, Binay, for having us here today. And I appreciate this question so much for so many reasons. And my core reason of why I share my story, I'm an open book, is to break the taboo of my family, the elders of my family, setting that tone of we don't talk about cancer or the big C. And that did such a disservice to my family, because honestly, I do not know my family history when it came to genetic testing, beyond what I witnessed at the age of 13, losing both of my grandmothers just 8 months apart. Ironically, at that same age is when I found my first breast lump at the age of 13. The size of an egg, it turned out to be benign fibroadenoma, but it also taught me about early awareness of my body. Fast forward 17 years later, I'm doing my routine check. I find a pea-sized lump. I knew what to do, and that was to immediately go to the doctor and have it checked out. However, I walked into a hospital system thinking all hospitals are equal, with blind trust and such naivety, not really sure about what I was going to experience. So I like to say I was misdiagnosed at the age of 29 and finally accurately diagnosed at the age of 30. Why? Because when I walked into that doctor with that pea-sized lump, I was dismissed. I'm sure you've heard these stories before. Well, here's another one. I'm too young to have cancer. Come back in 6 months. Came back in 6 months. That pea is now the size of a walnut. And by the time I got my diagnosis, I was already at stage 3 breast cancer. But it doesn't end there. I ended up with a botched biopsy, saying that my results were negative. But I knew from age of 13, I'm going to push for a lumpectomy, When I pushed for that lumpectomy, that's when they discovered it was invasive ductal carcinoma. So the treatment plan was aggressive, it was fast. I go in for that porta-calf outpatient surgery to have that inserted, ended up with a punctured lung because I received outdated procedures at this hospital just a mile away from my home that I trusted so much, that blind trust, which led to delayed chemo, inconsistent radiation, and the list goes on. But then I learned about American Cancer Society, which is a wealth of knowledge, and my trajectory changed from there. Yes, I now have to travel a bit outside of my neighborhood, but it's worth it. This is my life for a quality care, and that's when I learned about COC accredited hospitals, NCI designated comprehensive hospitals, and I'm proud to finally say I am getting care at an NCI designated hospital in New York City, where I live, Brooklyn, New York. So, you know, it's unfortunate that I had to go through that journey, but I don't take my story as a victim. I'm not a victim. I feel like I've been empowered and almost anointed to do the work that I do here at the American Cancer Society. So I learned about patient navigation, which is something huge and that we really focus heavily on, and even expanding into sub-Saharan Africa and in our global work. So I'm really proud of the work that we do here at American Cancer Society. I hope that answers your question.
Thank you for sharing that eloquently. That's just still is tough, though, because we got to fix that. I mean, we got to fix it in low middle income countries, but that should not happen. You know, that just should not happen today in America. So thank you for sharing that and giving us an opportunity to think about that. I want to ask Marianne if you could comment about, how can we make it so that people who do have families that, have a predilection for cancer can get access to screening. I mean, this is a huge problem because there's lack of knowledge, like LaToya shared with us, but there's also, there's discrimination for some people, and there's also a lack of access. As Julie, eloquently marched us through, if you don't really know what you're doing, you can't treat it, right? So can you talk about that a little bit?
Yes, absolutely. And I think even though we would love to start before the patient gets a cancer diagnosis, we're often left with doing the family history and all these things at the diagnosis of cancer in the first person in the family. But then by doing that, that opportunity is there to not only help the person right in front of you and help identify the risk factor that is there and do the right thing for the patient, but also take that opportunity to do the next step at the same time to help the sister, the brother, the sibling, and everybody else next to that. And we do not today have a systematic way to do this at our own cancer center and beyond in many other institutions. So having an embedded way to do this every time requires a lot of institutional support. I almost joke that I should really be at the door of Fred Hutch and just have people walk in. Do you have a family history? Do you need genetic testing? How about we just do send the test and we'll figure out the outcomes of what happens later? Because all the worries around the disparity, the insurance issues, or the discrimination with GINA and all these other things, they're kind of second line. If we can't get the medicine that is the trastuzumab or the rucaparib to the patient because they need it for their metastatic breast cancer, we really should not have to worry about all of these secondary things. Does that answer the question?
No, yes, but there's more.
Yes, and then for taking it on to the family members, I find that there are a lot of barriers in sharing in the family between people who have something that would really be life-saving for their relative or their family members, and we have a lot of work to do there for how do we break that cycle of fear, how do we empower people with organizations like Force and other places, how do we take that information that is life-saving to the next relative, either they're here or in Colombia or in different places. And I can share a story of one of my patients. How do we do this so they can actually access that information for themselves through color genomics or other places you can buy tests online, and then take it on to their doctor and say, I need an oophorectomy because I have a BRCA2 pathogenic variant. And I can share this patient story with you guys, because I had a patient who came to me as a female. Her father was diagnosed with prostate cancer in Colombia 15 years prior. And for 15 years, the family history was not disclosed or was not shared, and the father has a BRCA2 that was identified because the daughter went for a second opinion at a large cancer center, a consult, an e-consult. And the main message from the e-consult was, please have your dad tested. And when they finally tested the father, it helped him for his metastatic prostate cancer diagnosis and his medication as a PARP inhibitor, but everybody else in the family. And now the daughter that I see has had a risk-reducing oophorectomy.
Thank you so much for that great response, and very causes us to reflect. We're here sensing in the room that there are many questions, so we want to invite people to the mic, and as you come to the mic, just wanted to ask Dr. Van Loon maybe to reflect on the comments that you heard from Dr. Grelo, and then we'll take questions from the audience.
Sure. I'm sitting here sort of after listening to a presentation on access to global precision medicine, and also on the other side of me listening to challenges with access to oncology care in our own backyard, and there are so many similarities. And as a gastrointestinal oncologist, I see that day in and day out because we are receiving referrals of younger and younger patients, particularly with colorectal cancer right now, who are misdiagnoses. They're running through the system, they're presenting and not getting access to colonoscopies in our own system. So I do think that there are so many parallels. As I was listening to you speak about stigma, it reminded me also of one of the topics that we're talking about quite a bit right now in East Africa, and that stigma is right now around cancer diagnoses, and it is still a very, very pervasive theme. And I think in my work, there's so much to be learned through our own history in the United States and thinking about those stories. And really, it took Betty Ford, one prominent cancer survivor, to talk openly and publicly about her breast cancer diagnosis back in the 70s. And that really changed the narrative around a cancer diagnosis in the United States. But realizing here we are 50 years later, and stigma still exists in most of sub-Saharan Africa around a cancer diagnosis. And it's really interesting to think about how we work together to help change that narrative as well.
Thank you. Thank you for that thoughtful answer.
City Health Mayo Clinic, Dr. Grelo, thank you for that excellent talk. I have a question more so related to, I understand that obviously access to drugs and precision oncology is important, but also there is a parallel side to this story which is related to prevention, right? And how do we work on preventing cancer? But for all of these work, I think there is also this fundamental lack of general knowledge about what cancer is in this low and middle income countries. So as an example, I just got an email this morning saying, well, we have a BRCA2 carrier with breast cancer, what is her contralateral breast cancer risk? And we recently published in the United States one of the largest studies from population-based studies looking at contralateral breast cancer risk. And I was like, well, I can apply that study, but then I'm like thinking, well, I really can't apply that study because what is the baseline risk in Nepal? And is it different than United States, right? And that's really the challenge. So what kind of work is ASCO and other institutions doing to understand these fundamental questions in terms of population risk, how are populations different? And we can't really just take what we have learned from the US and just apply it in these countries. What are your thoughts on that?
So I think I could give another half-hour lecture in answering that question. You're absolutely right. We can't take research studies from the US, from Western Europe, and assume that that's accurate for the rest of the world. So we need to support clinical trials, clinical research globally. And so just an example of something we're doing, we have a Latin America Regional Council in ASCO that we recently formed, and we said, what ASCO programs and services do you want to translate to your region? They said, we want to do clinical trials here in Latin America. We're trained. We know how to do them. People don't come to us, and we don't qualify for grants. So we went out, we got a pharmaceutical company, thank you, Pfizer, who gave a bunch of money and said, through our ASCO Conquer Cancer Foundation, we're giving this to you. We'd like the research to be in metastatic breast cancer, but your regional council can put out the RFP, they can decide which grants are given, they can monitor it, they can do what they think is important in their region. And so the regional council couldn't believe it, that, that they would just hand us over, that they would have control. We had the application open. A week beforehand, we didn't have a single application started, and it made us very nervous. And everybody said, that's Latin America, that's Latin. We got 60 applications, and they just selected 7 that will move forward. And now our Sub-Saharan Africa Regional Council said, hey, we want that too. So that's just a little thing. You asked what ASCO's doing. That's a little thing that we can do, but that can help the people in the region set the priorities and do the trials. And then once they prove that they can do them, then they will get approached more broadly. They'll be more competitive for other kinds of grants, et cetera. And you talked yesterday, I think, about your D43 model where you're doing some training mostly with Tanzania.
Yes.
Yeah.
I did.
So.
Can I add one thing? So Dr. Phipps put up a slide of the Kaposi's sarcoma risk stratified guidelines for sub-Saharan Africa that has been put out by the NCCN. And the NCCN, ASCO, there are several groups that have put out risk stratified guidelines. That KS guideline is the only guideline that includes data for Africa from Africa. And that is a huge, huge need, addressing your question. But the data doesn't exist, and it is problematic that the way that these guidelines are generated is that they prioritize randomized control trial. They use tiers for quality of data, not where the data is coming from. So there is a huge need and a huge demand for more studies like what has happened with the AIDS Malignancy Consortium across other cancers to generate context-specific data.
Thank you so much.
Good morning. Matthew Miranda, Henry Ford Hospital, Detroit, Michigan. I'm a medicine resident. Thank you for your phenomenal insights to everybody on the panel. This question is actually for Dr. Grelo. I'm glad you mentioned that the WHO essential medicines is sort of just the starting point in terms of what are we determining need for. Obviously, there's a lot of controversy surrounding who determines that need and how. I know one of your slides alluded to survival benefit as one of these things, but I was wondering if you could comment on the role that quality and disability adjusted life years has in this determination and whether even these measures are enough.
Really good point. I think that the WHO essential medicines list is like, this is the basics. This is what you can go to your Minister of Health and your Minister of Finance and say, at a minimum, we are saying that these are valuable drugs that have efficacy, the toxicity isn't unbearable, that they're cost effective. Whether you put in quality at all, I mean, that's all very, very relevant. The message to a lot of these ministries is you will keep people in the workforce. You will keep mothers alive raising their babies. All of those kinds of things that go along with it. And it's all very valuable, and there are great studies being done, and the WHO just launched a global breast cancer initiative. Ben Anderson, our colleague in Seattle for decades, is leading that. And when we see the presentations on that, it addresses a lot of those pieces of it. But if you need something very equitable and fair and not too complicated to get it on the WHO essential medicines list, I think you can't add a whole bunch more things. But all of those are very valuable, especially in going and talking to the ministries about what you need and adding drugs beyond the WHO's EML. Because I think, like the ATOM project, it's starting with the WHO EML, but if there are other drugs that using additional criteria would rise to the top, they will go after those drugs too. Thank you.
Thank you. Great questions. I think we have time for one more.
Hi, thank you. I'm Erika Ruiz. I'm from Mexico. Thank you for your talk. I think that access not just to biomarkers but drugs, it's very difficult. It's a huge problem. Besides the government, corruption, etc., a big etc., I think that education, we should do something about education. I just run a trial, 400 surveys in general population, trying to know how much do they know about gastric cancer. These people were medium education, high school and over, and just less than 5% of those people know that they could have gastric cancer. So I think it's a great initiative from ASCO to do this on breast. But I would like to ask that it's not just breast, because it's so sad that now our patients come to the clinics and say, why I have cancer if I'm a woman, and women only have breast or cervical cancer. So I think we should go and try to do some great education for GI cancers. According to WHO, they said that at least for 2030, 60% of the patients, 60% of the new cases of cancer will be colorectal cancer for Latin America. So I will ask you if you please do something like you did it for breast. It was very successful. I knew because I have some friends that went to this application. But we need to do something for GI. It's not just breast. I mean, if we summarize all the GI tumors, for further, this is greater than breast cancer. So that's one opinion. And the other one is that in clinical trials also, it's very frequently that we see that most of the inclusion criteria is for Asiatic and European or US people. But what about the rest of the world? We are underrepresented. So I think that's another big issue, that big pharma should be more open to other kinds of people. Thanks.
So the FDA would totally agree with you. We've been part of workshops on multi-regional clinical trials and for registration trials anyway. So the FDA is very supportive of how do we do that. With respect to the focus on breast cancer, the 3 major WHO initiatives now, they started with childhood cancer because it's small and you get great success, right? So you need to prove that you can treat cancer in low resource settings. Then they did cervical cancer, with a big part of that, to get to one of the earlier questions, being on the prevention piece of it. So they have the Eliminate Cervical Cancer campaign, and then they started the Global Breast Cancer Initiative. They also have, in parallel, tobacco cessation, which is not cancer specific, and a pain and palliative care piece, which is also not cancer specific. So each one will be added on. You know, Catherine is an expert in global oncology, and she's a GI doctor, so I'm sure she would totally agree with you on adding colorectal, which is another huge cause. But you've got to do your pilots, prove the value, prove that you can do it, and then add on. And in Mexico, I feel so bad. I watched the Seguro Popular develop the Seguro Popular and then get dismantled by your current regime, which is a tragedy. So I'm sorry for what's going on, because you had built a great model of getting access in cancer and other diseases, and then politics dismantled it. And we're at risk of that too, with cuts to, Medicare, Medicaid, all of that. So we can't let politics dictate healthcare.
Thank you. And on that note, our panel ends. I think it's been spectacular, and I just want to call out that this is an all-woman panel.